Good afternoon and welcome. I'm Pascal Spothelfer, President and CEO of Genome BC, and I'm joining you from the unceded traditional territories of the Coast Salish peoples, including the territories of the Musqueam, Tsleil-Waututh, and Squamish nations. Before we got into this, I would like to thank the Genome BC staff who in the background have worked tirelessly to overcome our Zoom issues today that were due to a Zoom issue, actually, and not a Genome BC issue. So thank you so much. And now it's my great pleasure to welcome Dr. Penny Ballem as our guest today for a 45 minutes conversation about the challenges of mass immunization. Dr. Ballem is a physician, clinical professor at UBC, the former city manager of Vancouver, and was also Deputy Minister of Health in British Columbia. Given this resume, it is hardly surprising that Dr. Ballem was asked to head our immunization efforts in British Columbia. Penny, welcome to the Genomics Forum and thank you for being with us today.
Thanks so much, Pascal. It's great to be here.
So we'll have about a 30-minute conversation, which will be followed by a Q&A session in which you can participate by posting questions on Slido. And Genome BC team members will assist us by collating questions and we'll try to get to as many as possible. So let's get started kind of by looking back a little bit, Penny. When you were appointed as the executive lead for BC's vaccination rollout, I guess you didn't at the same time receive a mass vaccination playbook. So when you started, what status were our preparations at? How did you go about the task at hand? And what did you do first?
Well, I remember the day that I got the phone call, Pascal, and you know, I think I had the advantage that as the chair of Vancouver Coastal, I had a little bit of insight into where we were and, you know, what some of the challenges would be. But essentially, at that point in time, which was the third week of January, we had just started getting vaccine in, you know, the month before in very small amounts. You know, we obviously had the leadership of Dr. Henry and the minister right out in front on a daily basis, you know, setting the trajectory of, you know, what our whole approach was. So that was very advantageous. We had no digital system or platform. So we knew we were going to have to, until that was able to come on stream in what was really a miraculous period of time, we were working with what we had in terms of systems, you know, to reach the public, document our vaccinations, et cetera. And, you know, we were working in small hospital-based clinics because our focus at that time, and continues to be, the three legs of the stool, which are, you know, protect the most vulnerable first, and then move on to the general population, protect the healthcare system so it can do its job, you know, looking after the people with and without COVID, and thirdly, manage the pandemic. And so, you know, these, like, of all the focal points for us to have, you know, on a daily basis, remind ourselves, okay, have we lost the thread here of what we're trying to do? Those were the three things. And as we've seen, you know, our challenges in those 3 points of interest and focus have changed over time. Sometimes, like right now, managing the pandemic has been a major issue in protecting our hospitals, in some ways much more so than a year ago when we started this. You know, for the first few months of our vaccine, protecting our most vulnerable was absolutely the highest priority to get into those long-term care homes, get them vaccinated. But really, when I started, we had no plan for how we were going to scale up to immunizing 4.3 million people, not with just one vaccine, but with at least 2 or 3 and 2 doses in a very short period of time. It was challenging. There was lots to do, shall I say. It's kept me and our great team and all the health workers we've been in the minister, we've all been pretty busy.
So perhaps from a background point of view, I mean, the COVID vaccine is not the first vaccine that's being rolled out. No. There's flu shots, there is regular vaccinations that are happening. So what kind of data system infrastructure is in place or was in place when all of this started, and how useful was the existing data structure or data infrastructure for you to get going?
Well, that's a really good question. You know, we've learned a lot. I continue to learn, I would say every day, about, well, what is this piece of data infrastructure and how does it work? So, essentially, luckily, we had a provincial registry for vaccination. The reality is, though, that it only contained, really a fraction of the vaccines that were administered in the province. Because right now, our major campaigns are, flu campaigns, which are the biggest, and then the school-age children's vaccines. And, things like hepatitis B that we've got a, perinatal campaign and then the school-age campaigns. And, we use pharmacies, we use physicians, we use public health clinics to undertake those campaigns, but only a portion of those, over time do get into our provincial registry, which is the Panorama Registry. I have a special place in my heart in that because I was the liaison deputy in 2004 when we started the Panorama project. So I was fascinated when I came to Vancouver Coastal and they were all arguing about whether they were going to use it. I was like, whoa, 20 years later. But anyway, thank God we had it, because one of the things that was really unique in this campaign, besides the size, besides the number of different vaccines, they're very complex cold chain requirements. Pfizer in particular, -70, very fragile. You can't take it over a gravel road if it's been thawed. You have to thaw it at a certain rate. I mean, I don't even know all the complexities of, some of it, but very complex cold chain. And then, 3 different vaccines and just the order in which we were doing things. But we have been able to document every vaccination we've given every day by midnight that night into Panorama. That's never been done, not even close, never. And even the pharmacies, who, when we use them for AstraZeneca, they've never had to document it that day and that night. So, everyone's been like, it's been remarkable in that way. And now that we've moved on to a very, very sophisticated, very robust digital platform, where we're learning and we're basically building that airplane as we go. We're learning, over the weeks, the different things that it's able to do for us. And it makes it's just a dramatic shift from, kind of a series of tin cans and strings in each health authority, for communicating digitally around this program. But we've always had a registry that was there to put this stuff into, that we could draw out of and report every day on how we're doing.
Yeah, so how many people do you have on your team, by the way?
Well, I mean, I have a lot, because my team is all the health authorities. But, if I start with the Immunized BC team, we've got a bunch of people in logistics. There's probably, 60 to 70 people across the province who are responsible and at BC CDC for moving the vaccine around, receiving it from the federal government, moving it around, or making sure it gets there direct from, Brussels or wherever it's coming from. And then I have a very small team that I kind of plucked out of my past, a remarkable group of people who I worked with on the Olympics when I was at the city. And I asked them to come and help me because, if you think about it, they're experts. Here we had to be able, once we got out of our long-term care facilities, we need to start vaccinating very large numbers of people. And they're experts at, designing venues and models of people flowing through venues and doing different things and, being registered or frisked or tickets taken. And so they have expertise in systems around big events. They have expertise in patient, in flow of people through systems to get things done. And so there's 6 of them. And they have been really remarkable. And I think friendships and, learnings that we've had in our health sector from them have, truly been remarkable, because, if you think about it, we've set up vaccination centers in all around this province that can do, upwards of 15,000 vaccinations a day. And that's not an easy thing to do when you think about it. Most pharmacies, the most they could do is 300 a day. So this is these are massive organizations. And they also, through their, relationships which are long-standing with the business sector, which is such an important partner when you're putting on a mass sporting event. We've leveraged these incredible partnerships with, the airline industry, the cruise ship industry, a lot of the tourism and travel sector, most of whom had been completely laid off over the last year. And so we came together with them and the health authorities to plan these clinics and staff them up using people, in industry who have incredible skill sets in, patient flow or people flow and, safe systems and registration and documentation. It's been a really remarkable partnership, with like WestJet, Air Canada, the Canucks, the Convention Center, the cruise ship group, like a lot of really remarkable groups that have joined together with us to deliver this.
Yeah, no, it's fabulous to mobilize these resources, and it's interesting that you go back to a capacity that was built up for the 2010 Olympics. So that's another legacy that we may not want to forget.
That's right.
From that time. So one of the things, and that's again, there's probably a similarity with the Olympics. There is constant changes. The environment is constantly changing. So AstraZeneca was being used to vaccinate particular risk groups. And then the limitations to 55 plus came in. So you had to shift and go to general population 55 to 65. There is things that happen all the time. There's hotspots and things, etc. So the decisions that are done at the public health level have a big impact on the rollout, and at the same time, to what extent do your logistical considerations influence the public health decisions? So in other words, are you at the table when public health says, so we're gonna go and vaccinate all of Whistler? Or do you just get the phone call, go vaccinate Whistler, and you go? So how are these dynamics?
Well, it's a really great question, and I just think I feel very, very lucky to live in this province. And back when I was a deputy, we established the 5 geographic health authorities, the Provincial Health Services Authority that has a bit of a different role. It doesn't have a geographic population, but it's responsible for things that, move across all the health regions. And, because there's really a small number of us in leadership positions, together with the provincial health officer, with Bonnie Henry, and with the deputy, frankly, we've met every morning. For the first couple of months, every morning, like Saturday and Sunday included at 7:30. We let them sleep until 8:30 on Saturday and Sunday. And in the last couple of months, we just during the week, every morning at 7:30, and we discuss. It allows Bonnie Henry to bring what the public health people are thinking about. And we bring some of the, just as you say, the operational constraints and challenges with, whatever that shift or change might be. And, and then I've got the health authority CEOs sitting there, who are responsible for these operations. And so we're very, very fortunate. I mean, if I look at Ontario, oh my God, I can't imagine, how difficult it is to try and organize thinking and decision-making and trying to risk manage some of these shifts and changes that we had to and continue to have to every day. Just a great group of people, really a lot of collegiality, and we just all really care for each other, and we've worked every day, to just problem solve. And then, literally in the course of the day and the evening, just the ability to pick up the phone and phone the North and the CEO or the provincial health or the health officer there, or the senior ops people, just say, look, this has happened, your flight is delayed, do you know what to do, can we help? Just a massively positive ability to work together, make decisions, try and help be resilient and nimble, and to be able to react. Because as you say, just the things that happen, your cold chain breaks on the way to Terrace. Oh my God, what are you going to do? You've got a whole clinic set up, you got people waiting. What are you going to do? The arrival from Brussels on Moderna, 50% of the time, it was, from anywhere from 1 to a week, 7 days late. And, the AstraZeneca thing, like we were just on the move with all these essential workers. And immediately overnight, just by the age framing that the country decided on, it was just like completely wiped out that program. So we had to communicate with all of those worker groups and turn around and pivot within 48 hours and get that drug out to pharmacies across the province, and especially the Lower Mainland, given the surge we were experiencing, to at least keep it going, keep it going, keep it going, let them.
Yeah.
So I think we have a structure in this province that balances the ability for the health regions. They're big organizations, they've got scale, they can leverage things, but they're local enough that they can, it doesn't have to be one size fits all, but we're small enough in number that we can get together, like at the drop of a hat and talk about a problem, figure it out, regroup in an hour, and make decisions and get on with it. And then, the next day revisit it.
So for quite a while, certainly in the beginning, the biggest challenge was supply. Mm-hmm. Getting reliable supply of the vaccines.
Yeah.
And based on what I read in the news, there is now a steady flow of supply, certainly from Pfizer and from Moderna this month. On top of it, there is Johnson & Johnson coming in. So supply seems to have stabilized. Mm-hmm. But on the other hand, as you reach 40, 50, 60% of the population, there is this other 30%. So kind of the hard to reach part of our citizens. So how do you go about reaching them? Mm-hmm. What is in the plans there?
Well, it's a really important point. And, I just came off a federal discussion where we heard from a couple of the American states where, they've kind of flatlined, right? They've had all the enthusiasm of everyone who's clear they want to get vaccinated, and now they're having a bit of a struggle, right? We know that will happen. We actually know there's areas and populations in the province, we've already experienced some of that are a bit hesitant. And in some cases, we've seen that hesitancy has come along and people have moved to actually access vaccination, but there'll be a core of both geographic regions and populations where we'll have to go back and really work with them. We're doing a lot because we have another problem or a challenge too, and that is our digital platform, requires you to register and put in your communication, your email and your texting number, your mobile number. And if you're not registered, we don't have an ability to invite you anymore. And if you look at Fraser's, pop-up clinics, like that was a very legitimate attempt, to deal with the fact that they're in the epicenter of this surge at this point, and have always throughout the pandemic had, a significant level of activity on an ongoing basis. And they have a problem that they were struggling, as different parts of the province are, to get their public, where the worst case rates were to register, because if they're not registered, you can't invite them. And so the pop-ups were an attempt to say, well, just drop in. But with the population size they have, it's just very, very difficult, to manage just the flow of people in. So, I think the timing of that, probably was one that that we learned very quickly is not most effective. You've seen that the premier on down is working on a registration drive to get people registered, and it's been already, we're seeing a massive increase in people registering because they now understand why that's important. And even if they have to wait, for that invite to book as we move down through the age cohorts, but ultimately we will have to go back with pretty much on the ground, local, knocking on doors, mobile campaigns in little pockets of different communities, provincial level type communications. Like, we know when we're looking at vaccine hesitancy, it's a lot of work. But right now, and we are doing that to, a significant extent, but right now we're trying to drive through the people who want to get vaccinated and get them done, get as many dose ones into the herd as we can, so that we can then turn our attention to dose 2 while we develop another even more robust, more local channel to go after the hesitant populations.
So does the system allow you to identify who hasn't gotten the vaccine, or does it only tell you who has?
No, we know exactly who, well,
Okay.
we deduce it, right? So you have who
Yeah.
has been vaccinated, you know the population, you can track it by census tract. So,
Yeah.
you know, it's not overnight, but we have quite a robust ability to understand who's getting vaccinated and who isn't.
So you mentioned, so for instance, Quebec has started pop-up clinics, so they're gathering experience in doing that.
Yeah.
So how important is the exchange among provinces to learn from one another and have that exchange? Is that something that's happening?
Absolutely. So,
Yeah.
you know, similar to how we meet across our province every day, you know, Dr. Bonnie Henry is meeting with her colleagues, you know, I think twice a week or more, the provincial health officers across the country, and they discuss all these issues, you know, through I mean, many of us have relationships in different jurisdictions, you know, people, you know, I have contacts, you know, that go way back to when I was a deputy, even, and a city manager. So we do reach out to talk to colleagues that we know across the country. And through the NOC, the National Operations Committee that is distributing the vaccine, running the logistics, General Fortin, you know, we sit on, you know, Zoom calls with him and his colleagues on the operations side, from across the country on a regular basis. So we exchange. So I would say Canada has done a very good job talking to each other, keeping all these channels open. And as I say, I just came off a Zoom call just a little bit earlier where we were hearing presentations from different international jurisdictions and our own jurisdictions about, you know, challenges, things we've done, things we've tried. So lots of discussion.
So let's shift to the second shots. So the decision was made to get as soon as possible all eligible adults vaccinated with the first shot. The second shot will follow after that. And by any standard, it's once we have the second shot that we are officially vaccinated.
Yes.
So what challenges do you expect in that second phase? So by the end of June, the expectation is everybody who's eligible will have the first shot. We're at 1.8 million now, 1.9 million. And then we roll into that second phase. So what kind of, are you thinking about that already? Or are you saying, let's get this first phase done before we go there?
No, I would say we're trying to be ahead of the game. Because the weeks go very quickly, and before you know it, so we are already doing second shots, because if you think about it, the vaccine first started coming in December. So, but most of those people are kind of within our tent, right? They're mostly healthcare workers, long-term care. We did most of the long-term care second shots, but not all of it. You know, the priority populations that we did, the people in congregate living, corrections facilities, all those places who were pretty vulnerable and needed to be done up to the middle of March. In the middle of March, we started our general campaign. So we have a way to go. We won't have to start a second shot at 16 weeks till the middle of June for the general population. In the meantime, we've got various mechanisms, and now our system is now going to be able to tell anybody who's registered that they're time for their second shot. So we've got the system now that can actually do an automated reminder, but we're already planning. We know the vaccine we'll probably start big time second shots, you know, somewhere in the middle to the third week of June. And then what we'll do, Pascal, is we'll move people up, we'll just put them through as quickly as we can. So we won't stick to 16 weeks, we'll advance it because we know anywhere between 21 and 16, you know, it works, right? So So the second shot campaign, our hope is it will be much easier because we won't have the complexity of all these priority populations. We've had a lot of complexity on this campaign. We've had priority populations, healthcare workers. We have facilities like long-term care and independent living, assisted living. And then we've had, you know, clinically extremely vulnerable groups. We've had essential workers, like, you know, 7 or 8 streams of complexity. Now, as soon as they're done, first shot, they're registered, we'll just send everybody a reminder just based on time of coming in for their second shot.
So obviously,
sounds easy, eh? We're all going to put our feet up, we think, in June and July.
Exactly. Well, and all this is obviously happening to beat the pandemic. Sorry, but it's also to bring society and the economy back to life.
Yeah, for sure.
And so there's a lot of discussions around vaccine passports or vaccine evidence or whatever it is. So is that something is BC getting ready for, so that should a jurisdiction or a business or somebody require a vaccine evidence, a vaccine certificate, that we actually will get one delivered from the province so we can produce it?
Yes, so I think, as you know, there's lots of discussion about the sort of vaccine passport.
Yeah.
For sure, what we've told everybody, because a lot of people went and got vaccinated, got their little card. But everybody's in the registry. They're all in Panorama, and then those who weren't immunized while we were running IMS-BC will be backloaded in. But we will be able to issue people a certificate or some formal credential to say they're vaccinated, whether or not that's accepted by international authorities. We assume so, but we have the records and the ability, with just a bit more time, to produce something. If there's an international standard like there are for passports, that's a bit of a different thing. But generally, everybody will be able to, through a portal, eventually go in and get their own record, and their physician or nurse practitioner or midwife, physiotherapist will be able, through the Care Connect type sort of portals, actually have access to those records. So it would be fabulous. One of the most wonderful legacies of this whole thing is that we actually will have leapfrogged over all the issues that we've all been struggling with for years around records of vaccination and making sure everyone was recorded like that. Those days are over now. Now, if you get a vaccination in British Columbia, it's going to be into a registry right away. You'll be able to get a record of it yourself. It will be a whole different world, and we'll be so much smarter about where we have gaps in coverage, and be able to really target our vaccine programs, which to a certain extent we've been doing blind. We've been running it blind for a long time.
Well, I mean, if according to Anthony Fauci this morning, we will need certainly the COVID vaccine for the foreseeable future on a recurring basis. So having these systems in place is really a necessity.
Absolutely.
Just to deal with COVID as an endemic. So I have a few questions on Slido. So one of them is why BC isn't leveraging family doctors for the vaccine rollout.
Yeah, so we've had a lot of conversations about that, and a couple of things. So first of all, just the sheer scale of what we have to do and the logistic challenges. So some people, it took a long time for people to realize that our delivery of vaccine is planned 3 weeks in advance, and it's flown from the producer, international producer, directly to Fort St. John or Prince George or Terrace. So we had both Pfizer and Moderna being delivered in that way. So, and then there were the cold chain requirements and the documentation requirements. So everybody had to have access to the system to get it in by midnight, the night that the vaccination was given. And then so it could be uploaded and then reported on the next day. The documentation and the actual processes for cold chain are very rigorous and very demanding, and certainly not anything that any of our physicians or even our pharmacy community had ever had experience with. The physicians, just the rate at which they can vaccinate, we even know just with the pharmacies, we had a tremendous partnership and have with the pharmacies, both in past campaigns and in this one. Once we got a fridge stable vaccine, AstraZeneca, we, as you know, pivoted. Once our essential workers campaign kind of came to a close, we pivoted to the pharmacies and moved out about 180,000 doses. But even with hundreds of pharmacies, it takes quite a while for them to actually move it through, right? And when you look at the volumes that we're having to vaccinate and the capacity of these big clinics, like they're really, in terms of scale, there's no comparison. So to go back to your Olympics, mean, we have a deadline that we've got to get everyone vaccinated by, and we have to use the vaccine as it's coming in. There's a lot of pressure and scrutiny on that. So to use it as quickly as you need to maintain the cold chain requirements and to get the documentation, and then the logistics of getting it out to, there's, I don't know, 10,000 nearly general practitioners in the province. It's just not feasible at this point. In future, as they're brought onto portals, and as we get more fridge stable vaccines for COVID, which inevitably will happen, it may be a different situation when it's not so much an emergency, but really we're in an emergency right now, and it just hasn't been practical or feasible. But we have involved many physicians in our mass clinics, and they're, as far as I can tell, they're having a great time. They just are really enjoying the experience. Yeah. And find that, it's an environment they've never had a chance to be in. And I've heard many people just say it's been an incredible experience for them. So they're definitely here, but getting it into their each private office is not actually logistically advantageous for us at this point.
So one of the challenges as the vaccine, right now, supply comes in and it's being distributed because supply was tight. And we still can roll out, we can still distribute all the supply that we had, but there wasn't really much of a mix and matching that had to go on outside of the AstraZeneca vaccine where restrictions were in place. But as we get to the second shot, as long as mixing is not recommended, you now have to have a very precise supply to match it up with the requirements of the second shots.
Yeah.
So, and at the same time, there is the cold chain requirements and storage limitations, etc. So how is that being figured out? And are there systems in place? Could artificial intelligence help with that, or how is that being handled?
Well, it's a really good question. So a couple of things. We did have some mixing and matching in that we use Moderna because of its, it was a -20, cold chain requirement, which, is easier than -70 for sure. And so we use Moderna preferentially in all our First Nation sites, our 203 First Nation sites, because, they always had a freezer. And so, if you look at, and there was Moderna for sure used in the Lower Mainland and Victoria and the big regional centers. That's where we mainly use Pfizer, but we did use Moderna just because we didn't have enough just with one drug or another. But generally, as we have had to plan, and we've swapped around Moderna from different health authorities to try and have as much available to go back for the second dose in those small, more remote communities and rural communities. In the big cities, doesn't matter, right? But we are working on the very clear principle that until it becomes either, formally just doesn't make any difference, so therefore you can mix Pfizer and Moderna on second dose, or it's actually advantageous because there's some suggestion that there might be an advantage to using a different vaccine. But until those things are clear policy, our goal is to, as much as is feasible, to actually give people what they, the same vaccine as they got first. And only if it's absolutely logistically not possible will we actually cross them over. And at this point, we don't have the supply of AstraZeneca in sight, and we don't need it for a number of weeks. So it's not an issue at this point. But for Pfizer and Moderna, we're definitely trying to match it up. And we have modeling and all kinds of, it's not as artificial as artificial intelligence. It's still lodged in the human brain, but we're working it out for sure. And so far, and the one thing we've asked the health authorities is they were worried about running clinics with 2 different vaccines, but we said, look, it's not your ideal, but you can do it and make it safe and, just make it happen. So that's what they're doing.
Yeah. And so now we have 12-year-olds who will be eligible for the Pfizer vaccine at least. So I expect, that will be an additional element on top of the second dose rollout. So another element that you have to adjust to, and in 6 months we could see 5 to 12-year-olds getting the vaccine as well.
Yeah, so I'm going to be gainfully employed for a while, I guess, is my first conclusion. So the 12-year-old, or no, neither the 12-year-old nor every general population 16 and 17-year-old have still not been formally approved in policy in British Columbia. We have not got direction, but we're certainly planning for that. And in the discussions that we've had with Dr. Henry, I've said ideally it would be great if we can have a decision before school's out, because that's the best place to capture all those kids, is when they're still in school and go in and school campaigns are things that we have a lot of experience with, and a lot of they're used to it. Our public health folks are used to it, and operationally it will be a bit more massive, than the usual measles campaign or the boosters. But we're getting ready for that. It's not formally approved, though. I just want to be clear on that. So I think, like, in terms of public health, it's I think the best thing, as far as I can tell, to do. It's going to be hard to bring all this to a close with our youth not vaccinated. When it goes down to 5, we'll have to be ready for that. And that's the kind of thing, if we can figure it out, that either small, more neighborhood clinics or doctors' offices, we may be able to go there. But it's as long as we're dealing with the kind of cold chain things, it's not what doctors really have the infrastructure.
Yeah.
So we've got more to come on all that.
Yeah, I can imagine. I mean, and again, as you said in the beginning, you're building the airplane as
right.
You're flying it, and it's getting bigger and more complicated as the flight goes
because
on.
I would point out that we just brought in pregnant women yesterday.
Yeah, that's
and
another
there's
element.
about 35 to 40,000 of those in the province, and who can just immediately now come in, self-declare. We had to find a way to override the system, and every step of the way, scripts for the call center. It's very complicated, and you don't just say, oh yeah, great, go, so carry on.
Yeah,
it's every way you make it more complex, it's quite a lot of work behind the scenes.
So if you kind of look at the efforts made so far, what are some of the things you'd say, if we would do it all over again, how would we go about that differently? What are some of the key questions learned in your view?
Yeah, well, for sure, I would get my digital platform ready in advance. And having this, our platform is based on a Salesforce platform, which I never heard of Salesforce, but all the Olympians, oh yeah, we know Salesforce. It's terrific. And then a Deloitte sort of platform on top of that, and then a different booking platform. So quite a complex digital system, actually. But that would be really, really wonderful. And we have to, I would say our logistics people have done a fabulous job. But if we had to distribute ourselves, because the federal government has really helped us, right? Because our challenge is we have to plan 3 weeks ahead, which is a long time, as you've mentioned, given the changes. So 3 weeks ahead, you say you want so much to go here, so much to go there, and it just looks like a bunch of drones heading out over the province. And I think we will do some more work on our logistics function generally across the health authorities. We have some fabulous people that have been, just up in the middle of the night and doing all kinds of, heroic things to keep the vaccine safe and intact and healthy, and moving it around when necessary in our very big province. Like it's it's not the Lower Mainland. It's like miles and miles of northern terrain, or mountain passes. So like that's another area where we know we have some work. We just haven't had time, to do much, but continue to build that airplane. We now, as a result of this, have, quite an array of -70 freezers that are strategically placed all around. So we built a lot of infrastructure with a lot of help from our federal colleagues. They've been really quite terrific in assisting us with whatever we need. So then, and we've, we have all these legacies. We've trained so many different disciplines to immunize. So we now have a legacy of, a whole bunch of groups that can be scaled up and mobilized quite quickly just to put into a clinic. We have a model that's designed that we will continue to evolve, but it has been terrific. I think the biggest challenge we would have, Pascal, if we had something else that
it was an emergency alert.
That's an emergency alert, eh?
Yeah. Should we read it?
Yeah, this is a test of the British Columbia emergency alerting system.
Okay, test. It's only a test.
Only a
I think
test.
we can go on. We got the signal. Excellent.
So I think that the key thing that is really interesting is that we've accessed a whole lot of facilities, like convention centers and sporting facilities. If you think about where all these clinics are, that would otherwise be in use.
Yeah.
And the big thing that people forget about a pandemic is it is the human resource issue, is that you lose people, right? They're isolated, or they're sick, or they're looking after people who are isolated or sick. And that is, when you do a pandemic plan, it's like, how do you have business continuity with the HR impact? But, because so many people were laid off and things were working in a sector that has big facilities, we had lots of places to have our clinics. But, we would have to be able to mobilize, a pretty wide array of, pop-up facilities like these army tents and stuff that, people make. So that's another thing. And, I just think that there's a lot of different scenarios. And as you say, artificial intelligence, that we could plan ahead and start to build some infrastructure that would help us in decision making, that we had to learn, how to do that. Because, Excel and Zoom have made a lot of money off us in this pandemic. But and PowerPoint, I guess. But I think we'll have more legacies than kind of big challenges. We've learned a massive amount through this.
And that's fabulous. So last question. We have about 3 minutes, and it's kind of a question that follows on the panel discussion this morning, where there was quite a robust conversation around inequity and the comparisons between the developed world, where we are at 20% plus vaccines, and say on the African continent it's under 1%. And so the challenges you're facing today, we face them in an environment where there are systems in place. These countries will face the vaccination challenge in a much more difficult environment. So could you see yourself and colleagues in a next phase of that pandemic fight, to kind of share your knowledge and make your knowledge available to countries that will have to develop that capability over the next 12 months, year, two, which is ultimately a condition to really get that pandemic under control globally?
Well, that's a great question. And I would say, I think there's just a whole host of people that would be willing, not just to share our experience, but actually, maybe to go and help. Because I think the reality is, as you know, that if we don't get those parts of our world vaccinated, we're never going to get out of this. So from that pure point of view, it's definitely in our interest, but just the suffering, that is going on, it's just painful to watch, so I would say as a country and as a province, we have a lot of people that would want to find a way to make a contribution to try and help fix that.
Yeah, it's a real issue. I mean, yes, we can make the kind of the airplane breathing mask argument that you have to put it on yourself first before you can help others. But there is limits to that, as Michael Ryan and Bonnie have pointed out this morning. So Penny, this brings us to the end of that conversation, and I know that you have certainly a very busy day ahead of you. Well, we have a busy day ahead of us as well, but certainly a busy day ahead of you. So thank you so much for your time today and for your leadership in getting us all vaccinated so that we can return to a more or less normal life, which we'll certainly crave, and then extend the efforts on a global basis as well. So really grateful for your time and for your wonderful insights. Thank you so much.
Thanks so much, Pascal.
It's
a
a
real
pleasure.
Privilege. Okay, bye-bye.
Thank you. And just for everybody, our next session, Vaccinology and Immunology, Our Best Defense, is starting at 4 p.m. and you don't want to miss that. And to view the session, go to the event hub and click on View Session. So thank you very much and see you all at 4 o'clock.